JOFA listeners, and thank you for coming to this webinar panel on the topic of perinatal loss and bereavement. This afternoon, we have an hour, just an hour, with three superb panelists to discuss the struggle that many women and men face when they experience a miscarriage, a stillbirth, or early infant death. And we're going to try to incorporate some of the halachic, the personal, and the communal decisions that arise. I'm so honored to be hosting this panel, and we have three superb panelists who I'll introduce in a moment. This is the plan for our hour. I'm going to introduce the panelists in alphabetical order. Then each person is going to spend around 5 minutes describing her work and one or two important points that she wants to convey to the listening audience. After that, I'm going to be presenting questions or topics that have mostly come in from you listeners over the time that this webinar has been advertised, and people can write in during the course of the hour. And people will spend most of the time responding to those questions and comments. 5 minutes before the end at 1:55, JOFA will let you know how to access more resources and information. Okay, so our three panelists are Dr. Edith Gurewitsch Allen. Dr. Allen is an OBGYN at Einstein Montefiore. She's done a lot of research, actually, in shoulder dystonia and in obstetrical maneuvers and a lot of physician education. She has a master's of education in health professionals and has done a great deal in terms of health and administration. Our second panelist is Nancy Berlow, who is a clinical social worker, and she is at the National Council of Jewish Women, where she runs the New York Pregnancy Loss Support Program. Nancy trains and supervises all of the volunteer counselors who provide ongoing care for this Pregnancy Loss Support Program, and she facilitates support groups and conducts one-on-one support sessions.
Like this so you can hear it.
Our third panelist is Reva Judas, who is the founder and executive director of NechamaComfort, an organization that supports families dealing with infant and pregnancy loss. Reva has counseled many, many people, and her training is through chaplaincy certification, and she's also been very involved with Resolve. Okay, so we're going to start off with Dr. Allen speaking for a few minutes.
Thank you, Dr. Friedman, for that introduction. And I wanted to just add a little bit in terms of my bio. I am a maternal fetal medicine specialist, which is also known in the vernacular as a high-risk pregnancy specialist. And so the issue of perinatal loss is one that I handle on a daily basis clinically. And I myself am Orthodox, and I have patients who are Orthodox, but I obviously treat all women. This topic is actually one that I suggested to JOFA as one that is an unmet need, I believe, in my interaction with Jewish patients and Orthodox patients in particular, because of some of the halachic issues that come up as we're dealing with the immediate treatment and care, both physical and mental health, for women who suffer or will be suffering a loss. In terms of the way that this type of situation is different than it is for other encounters within pregnancy care, is that not every pregnancy is planned and not every pregnancy is necessarily desired, but in the cases that we're talking about, the pregnancy was highly desired, often hard to have achieved, and the loss is a shock and traumatic for the patient and her family. The way we handle the discovery of either a stillbirth in utero or of a significant fetal malformation that's incompatible with life is first, of course, to counsel and share the bad news, which in and of itself is difficult. And then to go through what is actually going to need to happen in order to deliver. There's still, depending on the stage of the pregnancy, in most cases, the need to go through labor and delivery, issues of pain management, issues of the milk coming in. There will be bleeding, and that will be the same as it is for any other postpartum patient. And so that's actually in and of itself, because of course there isn't the wonderful gift of a new life, just pain and not any joy. And it becomes all the more difficult when there are issues of being able to touch your partner, and when can you resume trying again, as well as other issues that come up. And I think I'll stop there and open this to our other panelists and to questions that may come from our audience.
Thank you. Ms. Berlow, if you could, your time.
Okay, thank you. I'll also give a little more background about myself. I, as a social worker, I worked in a very large hospital running the pregnancy and infant loss perinatal bereavement program. So I had experience with patients at the time of their loss, with them sometimes in delivery, sometimes after, advising them on how, what resources were available, and following up with them post-discharge, and helping them plan funerals, and giving them support. Currently, I am with the Pregnancy Loss Support Program through the National Council of Jewish Women, New York, and we are give support to women and couples at all stages of loss. I want to talk a little bit about the perinatal loss itself, which is something, is a very under-recognized grief. It's an under-recognized loss. And we know that many, many, many people are touched by it and do not find the support that they need. We call it also a disenfranchised grief. Disenfranchised grief is a type of grief that really people feel very disconnected from societal norms of grief. With perinatal loss, it is so, it's at so many different stages. It's often not a tangible loss. If it happens at early stage in a miscarriage or second trimester, and then of course stillborn and newborn infant death is more recognized, but the recovery from it and the support often wanes after time. It's also important to recognize how couples manage the loss, and what often is the case is at the time of a loss, couples are very much together at the same place, devastated by the experience. And as time goes on, there's a diverge in their experiences, often due to societal pressures. A man will go back to work and a woman will still be home healing and coping, and they will end up be at different places in their experience and in their healing and in their emotional space. And it's very important for couples to keep communication open about how they are experiencing it, and being open to the fact that their experience may be different, but they're still both going through something very emotional and important. So it's very important that we explore ways and help people understand that it's okay to have different experiences, but to continue to get the support that they need.
Okay, thank you for those important comments. Ms. Judas.
Hi, good morning. Good afternoon. I want to thank you again for inviting me to this really important panel. NechamaComfort began actually 31 years ago with the death of our firstborn son. He lived for 12 hours. He had a congenital heart defect. And at that time, there was no support, both in the secular world, the Jewish world. We were told, don't go for therapy. Why do you have to go for therapy? You know why you're depressed. Just go home and get pregnant. And we did that, but we were still very much depressed. And we would be searching, my husband and I, for any type of support. And as the years went by, I continued teaching. I'm an early child teacher, and really saw that it was difficult to find the answers to the questions. People would start calling me unofficially and nowhere to turn. So really now, in 2008, we formed our organization officially. I work with 3 other women volunteers, and it exists to help everyone who experiences infant pregnancy loss at any time. The husbands, the wives, the grandparents, the siblings, the children, as well as anybody else in the community. And we're available to work with the families from the moment they call us for as long as they need us. We're global, so we get calls, literally text, emails from all over the world. And we offer individual counseling, support groups. We help with decisions that need to be made from the beginning. We guide family with choices. The most important thing is that we want the families to have all the choices that to help them make the right decisions for them. And if we come to them at a later stage, if they've already gone through the burial and the beginnings of the grief process, we help them to understand that they did nothing wrong and that there's always time to grieve and to lose and to deal with the loss of their baby. You know, what our mission is to tell people, we don't deal with it and go past it. We help to put this loss of a child into your lives and to move through it. One of the things that we also realized early on was that education is extremely, extremely important. None of us, as well as intended, could be everywhere at the same time. So we run community awareness programs to help people understand how to deal with other people's infant pregnancy loss, how to deal with their coworkers, how to deal with the woman at the grocery store who they see every week who lost the baby, the do's and the don'ts, what to do, what to say. We train clergy and medical staff, kala teachers, yoetzot, maharot, mikvah attendants, and the members of the burial societies, the Chevra Kadishas. We work with all denominations, from the atheist Jew to the ultra-Orthodox Jew. Excuse me. And we really help where help is needed most. One of the things I wanted to do is just to highlight a couple of the questions that we sort of focus on at NechamaComfort. We've been privileged to have many people help us learn what we call the non-Jewish laws, the non-halachas. If a child passes away over the age of 30 days, then after birth, then the same laws apply to that baby. If a child is under 30 days, there is no written Jewish laws how to deal with their loss and grief, from the burial to the naming to any other questions that the couple may have. I sort of look at it as in this horrible situation, the couple is given sort of a pass that they don't have to follow the Jewish laws of mourning and grieving, but they can follow the Jewish laws of mourning and grieving. And to remember, as was said before, men and women are different. And it could change. Their feelings, their needs can change daily. And to know, for example, many of our Jewish, what we think of as laws, is tradition. So, women, men, all over the world, many people light 2 candles on Shabbat, but there's nothing wrong in lighting as many candles as you want, including one for their child that is not living with them presently. So I hope that this really, serves the purpose of educating the communities and the couples moving forward.
Okay, all 3 of you have brought up points that we're hopefully going to expand on. So what I want to go to now is your advice to people on really the topic, which you've all touched on sensitivity and what to say. Ms. Judas just mentioned the grocery store person. A number of people wrote in comments of that have been really painful, difficult to excuse as an understatement. Stuff like, you're young and you can still have more. Baruch Hashem, it was an early loss. You never know. Maybe the fetus had a disorder. Maybe it was a neshama that needed a tikkun and you were the special one to carry that mission. People don't mean badly, but they say really hurtful stuff. What is your advice for how to respond when somebody says something that is really painful? I don't think people in the phase of their own grief can really be expected to educate others, but how can we do better?
I think that the most important thing is to be comfortable with ourselves, that to take a moment, maybe after the webinar, to say we may be uncomfortable at the loss that somebody else is going through, but we need to. And really less is more. I think acknowledging their loss by just saying, I'm so sorry, is really the first step. I know the thousands and thousands of people that we've spoken to, the comment that I get mostly is, this person didn't recognize the loss. And that I think it is so important, even if you felt like you said the wrong thing, to acknowledge it and take the lead from the couple. And, really just to see how they're talking about it, if they want to talk about it, and just say, I'm so sorry, I'm here to help. And one thing that we always try to educate people is not to say to the couple, how are you? We know how they are. We try to just say, how is everything? And that gives them an opening to either talk to us, not talk to us, and to understand that they're going to go through stages of being social, being not social, and just knowing that you are there is extremely important.
Ms. Berlow, or
I'd like to add.
Yes.
So I think there's actually 2 sides to this equation. In some cases, the parents are actually asking, they will ask me at the time of the diagnosis, how will I tell my family? How will I tell my kids who are expecting a sibling? And in some cases, they hadn't actually disclosed that they were pregnant to begin with. So it varies from patient to patient. I would absolutely echo what Reva had just said in terms of how we show our support as a community. I also think if someone did say something, we hope inadvertently, that is hurtful, maybe give them the benefit of the doubt and allow someone to apologize. So I think that if someone feels hurt, that they should say, maybe you didn't know, but I recently had a loss. I think being open and honest, obviously to the level of a couple's comfort, is important, because I think a lot of the pain is the not being able to share, or feeling as though they can't, or nobody wants them to share, or it was a secret or something like that. That type of thing, as we know now, when we understand more than we ever did about all kinds of trauma, secrets aren't helpful therapeutically, and they can lead to a long-term problem. So I generally encourage my patients who are experiencing a loss or just experienced a loss to that doesn't mean you go and tell everyone, but obviously people who are closest to and you would look to for support to share what has happened. And if someone does say something inadvertently, they knew you were pregnant, or they knew that your daughter was pregnant, and they're meeting you in the grocery. Oh, isn't she due anytime soon? And you hadn't really said anything. That it's okay to acknowledge that I know you mean well, but that doesn't really help. Or what would help is if I just knew that I could count on you to be there, both when I'm hurting and when I'm have joy. I think that would be very helpful.
Okay.
Yeah.
Can we just move to first names?
Can I just add? I just want to say that
Yes.
one of the things, if people are being, it's really echoing what has been said, but to say, I appreciate that you care, but this is a very difficult time for us. To be able to also, as Reva also said, it's a time where it might be difficult to educate people, but it's important to state what your needs are and to be able to explain that, what it is that you're going through and how difficult it is, and that you're looking for support at this time.
Okay, thank you very much. I want to back up now and go to prior knowledge is kind of the heading. Is there any way to detect in advance that let's say recurrent pregnancy losses? What are common reasons for that? And is there a way to prepare for pregnancy ending? And included with that, do you think college teachers should bring up the possibility of miscarriage? This kind of goes with should college teachers bring up the potential of infertility, which we know is 1 in 6, and some people say no, you shouldn't say that when people are building a marriage and they want to be happy. But should this be part of education? So we're talking about the overall questions here. I know it's kind of mixed. What are possible reasons for recurrent loss? Is there any way to prepare? And do you think that women should be educated in this in college classes?
So from a medical perspective, recurrent pregnancy loss is 2 or more losses. It's actually, I think, from an education perspective, we know statistically that actually 50% of all conceptions will end in a loss. Most of those will be maybe a slightly delayed onset of a period and what we call a chemical pregnancy, but it's actually fairly common to have at least one loss, and especially in a community where there is typically lots of pregnancies. Women will experience that more commonly than if they only have 1 or 2 children, 1 or 2 pregnancies in their entire reproductive life. So it may feel to some as though it's happening more to them, but in fact, loss of a pregnancy is fairly common, and it's almost certainly in the first trimester due to just a chromosome abnormality related sometimes to age, but not necessarily. It's just a kind of an accident of conception. And that's generally how we approach it when it happens for the first time in a first trimester situation. A loss that is beyond the first trimester, the most common cause in that circumstance is related to there may be an abnormality in the uterus or in the cervix and being able to hold a pregnancy, and doing diagnostic tests between conceptions can sometimes bring to light those kinds of structural or anatomical contributions that there is treatment for, either during the next pregnancy in the form of cerclage, which is a stitch that we use to sew the cervix closed, or to remove a septum that may have interfered with proper pregnancy development. In the third trimester, the most common, already it's far less common, and especially today when somebody's getting regular prenatal care and undergoing testing if they have a high-risk pregnancy, but we will still see losses related to, often it's bleeding, premature separation of the placenta, or a category we call a cord accidents, where the blood supply to the baby was cut off, and usually totally random event, and thankfully quite rare, but still very shocking and terrible when it happens. As far as being prepared, I think that it would probably be no more appropriate to bring up the issue of there's a good chance that in your reproductive life you'll experience a miscarriage as part of the first pregnancy visit when somebody's already pregnant. So I'm feeling as though, maybe talking about educating somebody that it's possible is not the same thing as sort of just taking it as a potential given, and saying, if you ask specifically about college teachers, to say, here are the rules of NIDA, and hopefully this shouldn't happen to you, but if there was ever a miscarriage, this is how the rules would be applied in that circumstance. It's in a very matter-of-fact way that doesn't have to do with scaring anyone, but just actually, even by demonstrating that that's part of the teaching, I think would demonstrate also just an awareness that there's a likelihood this could happen to someone, without necessarily saying, oh, I want you to know this could happen to you. But you could just say, this is how we modify things.
Thank you.
And yes, there is treatment, chromosome issues. Sometimes there is something that is recurring. There's what we call a balanced translocation, and so more of the conceptions could end in a miscarriage. And there are ways to use assisted reproductive technology to get around that. So we do work up, if there's more than 2 losses, quite extensively in the first trimester. And as I mentioned already, the other causes later on, thankfully, are usually not recurring.
Thank you.
I just wanted to touch base a little bit about the educating and the college teachers. With our experience, both personally and professionally, we've done a lot of education over the last 10 years. And we've encouraged many college teachers, or the go-to person that the couple will go to, both the man and the woman. So when we say we educate rabbis and college teachers, and it's not just about the laws or the non-laws. It's really about things of this matter. We talk to them. We talk to the young couples. I've gone into high schools and spoken to children there, the students, and we encourage the educators to just mention it. Not just infant pregnancy loss, but infertility issues, spousal abuse. I know they're much more open in the Jewish high schools about all of these things, and our children are exposed to it. And I think mentioning it and saying this may happen, and you can give them statistics or not, will not burst their bubble of a wonderful life. But it's really, being a kindergarten teacher, we watch the kids from the beginning, and they go into the housekeeping area, and we're going to get married, and we're going to name our children, and we're all going to live happily ever after. But we know that's not true. And I think that we're fortunate enough to have webinars and to have social media and to talk to our children about things that we weren't able to talk about. I tell when I speak, and I tell my own children, you know, nobody talked about cancer, nobody wore pink in October. But now it's so important to be able to talk about it, that just informally, you know, I will not hide the fact that I had my firstborn son died and that we had 6 miscarriages. But I tell my living children and their friends and their family what happened, how to incorporate in their lives. So it's very important just to naturally to get this point across and to know in terms of the college teacher, the rabbi, that they're with you also for the rest of their lives. Sometimes I'll get a call and the call will say, hi, Mrs. Judas, or hi, Mo or Reva. And that will be somebody that was given our number. And they'll say, you know, even their first miscarriage, because, you know, the attachment to the baby is so early. And we plan in so many ways that is a loss, even at 4 to 5 weeks. And we have to deal with that as well. And I like seeing that the education is working. A couple days ago, my son texted me, he's 20, and he said, hey, Mom, I just saw an ESPN sportscaster lost a baby. Can you call him? And that made me feel pride in that, you know, the next generation will be more comfortable with it. So it's really educating and making it a part of all of our lives to talk about it.
Thank you. Nancy?
Yeah, I also want to mention that it's important that if women feel that they have concerns, that they should address them early with their medical professionals, with their doctors. They should get support. They should, if they've had one miscarriage, they will want to, they might want to be monitored much more closely in the future. And if you want to find a trusting obstetrician who will give you that support and openness. If you want to go every week for an ultrasound, that you can do that because you need that reassurance. And you need to be an advocate for yourself. It might be a new role for women to play in their lives, because in the past they feel like they have their trust in their doctor, but they have to trust themselves, do their research, and find ways to get through the next pregnancy. We also give support in our program for pregnancy after loss. So we know that it can be a very difficult experience until someone has a positive outcome. So it's very important that people look for support throughout, especially from their medical professionals.
Thank you. I want to go to the topic of burial and other ceremony options. So I'd like to ask each of you to speak about burial of either a fetus after miscarriage or a stillborn or very early loss. And any aspects of this, from dealing with the chevra, from dealing with the funeral home, from rites, ceremonies, misconceptions of what's halacha, what's minhag, really any aspect of this painful and very necessary subject. Nancy, maybe you want to start off.
Okay, I will approach it from a couple of aspects. When I worked in the hospital, we actually developed a policy that we gave every single loss at any gestational age the option or the education that they had every right to bury or cremate. We were also dealing with people who would wish to cremate the remains, the fetus, the baby, whatever terms we want to use. It depends on what gestational age. And there were many people who had no awareness about it who then chose that option. Those plans are made, at least in the area that I lived and was working in Long Island, through the funeral home, would make those arrangements for the couple, and they would do, at any gestational age, they would find a way to bury or to cremate those remains. In New York State, it is required at 20 weeks gestation and above that the baby be buried or cremated. In the 5 boroughs, there's a different interpretation, and they will do it for you up to 24 weeks gestation. A hospital will handle the remains either in a Potter's Field situation, or through the Chevra Kadisha, or through or a couple can make their own plans through a funeral home. And there are many cemeteries, Jewish and otherwise, that have sections just for babies.
Thank you. Reva?
So this is one of the areas we've really dealt with a lot. And again, we're grateful to the many hospitals, as Nancy had said, who are aware of the importance of giving the family the choices for burials. So how we come in is we sort of, through education and through dealing with the couple directly, explain to these couples, these Jewish couples, that they have the same choices. Sometimes what happens is an older generation or a more religious family member will say, okay, we'll take care of it for you. And there are times, and unfortunately still today, that couples, somebody else, they call a certain Chevra Kadisha, and they just take the baby and say, we'll take care of it for you. We're going to bury the baby. And the couples are told that they can't know where the babies are buried. So what's important to know, and when we speak to the all over the Jewish communities, to the rabbis of those communities, is to make sure before the situation happens, to know which funeral home to work with, which cemeteries are going to be accommodating, which burial societies. In New York, New Jersey, we have quite a few. Out of town, there's really one funeral home and one burial society. So it's really to know that the couple is permitted to bury their baby, and we refer to them early miscarriage to the age of 1 as their babies, to name the baby. Sometimes they'll feel the Chevra Kadisha will say, we'll name the baby for you. And we still get calls now from couples that say, how can we help? If that situation does arise, we work very hard. In most major cities, there are records, and the couple can know where the baby is buried. They are allowed to know that. The couple has the choice to either bury the baby in a area where all the babies are buried, or they are able to bury the baby in a family plot or in a plot that they would like to use. We have a wonderful funeral home that we work with in New Jersey, but we do have connections to many more. And it's important to know that they are able to put up a stone for the baby. Some cemeteries and funeral homes will tell you that you can't, but you do have that right. And that's why it's so important that we all are able to talk to these couples and to educate as many people as possible so they have their choices. They're allowed to have an unveiling. They can do anything that's related to the burial, they are allowed to do.
Thank you. Edith?
Yeah, so from a medical perspective, it's true that there are regulations, and often where this comes up is not so much about burial, but actually the requirement for an autopsy. For example, in some SIDS cases, or maybe all SIDS cases, depends on the region, it's required to go to the coroner for an autopsy, and that has halachic implications, and it can be very traumatic, obviously, for a couple if they don't want it. On the other hand, from a medical perspective, sometimes when there is questions of what exactly caused the loss or the death, the medical community may be asking or suggesting that an autopsy would give more information. Often those autopsies don't yield information that is helpful for the future. And I think that there should really be more equipoise on the part of the medical community about strongly recommending an autopsy to someone who really is disinclined against it. The other thing that I think comes up in terms of the psychological healing, we know from years of experience that those couples, and especially the women who experience a stillbirth where there's a recognizable fetus, those women who will hold the baby, at least look at the baby, accept gifts of whether it's a lock of hair or a footprint or a hat that touched the baby, and accept those as mementos, they heal psychologically in a different way than those who the baby was whisked away, what they never got to see it. On the other hand, the issue of touching a dead person is also has halachic issues, for at least for some, perhaps Kohanim I'm thinking of, and so balancing those, what we now understand better about recovery, and processing, needs counseling as well.
You anticipated, let me just expand that, because Edith, the last thing you talked about was exactly, and Reva, maybe you're probably picking up on this, where I wanted to go, because people who are listening, maybe people who have experienced loss, but there's also medical professionals, nurses, doulas, midwives, all kinds of people. I mean, this is really an educational webinar. So I want you to expand, each of you, on this topic of what you advise. Obviously, we believe in people making their own choices, but exactly on what Edith was talking about. When people say, well, what should we do? It's the immediate moment. They don't know. They haven't expected this. Do you advise giving names? Do you advise taking pictures, holding the baby, taking a lock of hair? Some places give little boxes, for keepsakes. What would your advice be in terms of offering? Obviously not mandating, but I think, Reva, that's probably where you're going to go, right? And then Nancy.
Yeah. So I just wanted to touch a point, because she said it is about educating. And one of the things that we've learned, and not just we, the rabbis in all denominations have learned, is that, again, because there is no Jewish law written about babies under 30 days, there's nothing, for example, stopping us. If a couple is offered an autopsy, we want them to have that choice. It's interesting because many hospitals know, as Edith had said, we don't do autopsies, this is the Jewish person, hands off. But we want to educate everybody to say autopsies are allowed in any situation for a baby under 30 days. The other step is in terms of, we're told not to touch, any person that has died. Again, under 30 days, everyone, couples can touch the baby involved, even if the father is a Kohen. We've worked with many people with that. So it's really, again, about being able to offer the couples and not to give them this extra stress of this one saying, don't do this, don't do that, don't do this, don't do that. The couples can hold the babies. We try to really have the couple choose a name for the baby at any stage. It could be a name that they want to use publicly out loud. It could be a name that's never discussed. Because what happens to that baby that has passed away, and future babies, hopefully, will be that child would be referred to as the baby. And it'll make it difficult for moving through their grief. Even if, when the baby was in utero and you called the baby Sunshine. I know couples that on their, they would put a rock and paint the sun on the matzeva. And, when I was dealing with my loss, society wouldn't let us talk about the names of the baby. And once I was able to free myself and publicly put the picture of my son, Pesach, on the wall with my children and grandchildren, it does, as Edith say, makes it so much better. So we do everything that the professionals, the medical staff, the social workers, the therapists suggest. We want the Jewish couples to know they can have those choices.
Thank you, Nancy.
Yeah, I also agree with everything that Reva said, and I think it's important if family members or staff, hospital staff, can take those pictures, take handprints, footprints, locket of hair, mementos, and even set them aside if couples feel that they do not want them at that time, and make them available in the future. Because what can often happen is at the time, the couples can be in such shock, they may not be able to they might believe halachically that they don't want to be near the baby, or they might feel like they need to do their research, or it's not for them emotionally. But very often it is found that they will come back. It could be weeks, months, or years later. And I had a situation in the hospital where it was the baby's, it would have been the bar mitzvah year. And the woman contacted me and said, "Do you have pictures?" And we had pictures. She had never looked at the pictures, but we had saved them, and we were able to give them to her the year of her son's bar mitzvah. And we also encourage people to feel that they can name their baby at any stage, the same as what Reva said. They can name it years later, because that way it's giving a memory to that baby and honor to that baby, but also giving them permission. If they feel that they can't, then they can't. They might want to refer to it as, baby Smith, or our baby in heaven, or however they want to refer to it, but to have some kind of way to reference that baby. And it doesn't have to be the hours or days following the loss. It can be done at any time. And we want people to know that they have permission to do that, so that they can, it gives credence to the loss.
I just wanted to point out two more things. I think actually what Nancy just said, that often in the shock of the moment, couples are actually, taken aback by a suggestion that they should hold the baby, that they should see the baby, and they often. But part of the counseling is to say, often the imagined is worse than the reality, and so we still try over the course of a labor to encourage without being overly coercive. But we actually do have that as a policy to take those pictures and do our usual routine, even if they don't avail themselves of it during that hospitalization, because we have the same experience that couples do come back, and the regret factor in terms of not holding is high. So I completely agree with that. I did want to point out one other medical issue, and that is that typically at a burial, a bris is performed, and some people aren't aware of that, and that is an opportunity to actually give a name. The other thing on the flip side of that is that it's not always possible, even if it's a fetus that is large enough to be distinct, to determine the sex of the baby when we look at it. And so that can be, people have to be prepared that may be the case, and therefore assigning a particular name may not be facilitated because we don't know what the gender is.
One last question for me, and then a few moments for you to say anything you'd like. Any specific advice that you have for the fathers, husbands, spouses, partners, and also something that was touched on before, how to tell children, older siblings, in a situation of loss? Who'd like to go first?
I'd be happy to. Fathers, I feel, can often feel neglected.
Yes.
And we really think it's important for them to have the opportunity to express their experience, their loss. their disappointment, their anger over what happened. You know, there's a lot of anger post loss that people don't have an opportunity to talk about. And fortunately, in our program, we offer very good support to men separate from women if they want, or as couples through telephone counseling that people can get given support, men male to male or couple to couple, and men participate in our support groups as well. And we have one night when the group separates and it's separate men and women, and the men talk about what their experiences, and we find that to be a very valuable and powerful experience. And men often feel that they need to be the the caregiver, the fixer, the one who has to make the arrangements, and it can be a very difficult experience. And it's important for that to be acknowledged, even if we can't exactly change their role in having to make the arrangements or to be taking care, being the caregiver at home. But it's important to acknowledge that they are also hurting, and for them to have the opportunity to find a safe place to talk about it.
Agree 1,000%. And that, that was always the population that was ignored, Nancy. And we've seen now how much healthier it is for the men to be expressing their grief. In terms of the children, we feel that, again, honesty, what I had said before, children are exposed to everything now, more than everything. And the most important thing is to be honest. Sometimes in the past, we had worked with a couple that lost a baby, and the grandparents would come in and they would say, "We know how you feel." And it was the first time that the couple who had just lost a baby had heard that her parents had lost a baby and never told her. So again, we had mentioned secrets and silence. We encourage, and that's what we're here for too. We give guidance and we help the couples working with the other children. Very simplistic, based on your child's age, to tell the child that the new baby was very, 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 very sick, and to say very, very, and to say it is a sickness that only babies get.
Yes.
And that's important for them to understand if they get a cold. And throughout the years, for example, we had suggested lighting a Shabbos candle. If that's part of your life or other things, to sort of incorporate that child in your life as your children get older. I know with my own family, I asked them once, my 4 other children, when did you know that we had a son that died? And they said, we don't remember. It was always there. At a certain age, we bring the pictures out. We take them to the cemetery. We put this child into a place in our lives. And I think that's so important. I told the story a little while ago about my son, and these are the next generations that will grow up and hopefully not have any bad situations, but we know they will. So really, it's all about honesty to everybody and the children. There are a few books out there that can help in certain specific stages. And we get calls from many authors all the time to write new books. So that's what's important, honesty.
Okay, Edith. Edith, do you have some thoughts you'd like to share?
Yes, I think it's very much age dependent. I think that it's important to share with other support people in the family who may have a little more distance, because often, parent is grieving on their own and then feels as though they need to be in a position of strength or non-reaction in order to help their children. And it might help if a trusted aunt or uncle is there to answer questions that may not trigger the same emotional response in the aunt and uncle that it might in the parents. So I think it should be a family decision about how to manage expectations loss. But again, I absolutely agree that honesty is best, and timing is a family decision, but ultimately I think it should be disclosed at some point. I don't think it should never be told.
Okay. You know, I just realized at some point before that I forgot to introduce myself. And I'm Michelle Friedman. I'm a psychiatrist in private practice, and I'm the director of Pastoral Counseling at Yeshivat Chovevei Torah Rabbinical School. And I found myself extremely moved during this webinar, and I want to thank JOFA and the three of you for the privilege of moderating. At this point, we're going to turn it over to the JOFA professionals to advise listeners how they can access resources that JOFA has. And I know that there's, even during this call, this webinar, somebody wrote in asking about the books that Reva, you mentioned, books for children, but there are many resources, and please tell us how to do it.
Hi, everyone. My name is Rivka Cohen. I'm the program manager at JOFA. Thank you all so much again. I also was deeply moved hearing all of your experience and stories and advice and everything. So thank you so much for this webinar and for all of the work that you are doing. For everyone listening, you can join JOFA's email list, or you can email me personally at Rivka, R-I-V-K-A, at JOFA, JOFA.org. And I will compile some resources from our panelists, and I will send it out to everyone who is on our listserv or who reaches out to me directly. So thank you once again. If anyone has any last thoughts, feel free, and then we will be done.
Thank you, JOFA, for organizing this panel today. In a way, you know, I always get excited and happy, which may be a strange word to use, when something like this occurs, because it really helps so many people, and it's the awareness and the education. And thank you, and Nancy and Michelle and Edith, and we look forward to working with you all together many more times. So thank you.
Thank you again, and thank you for the opportunity to participate.
Absolutely.
I learned some things here as well, especially, you know, that people are allowed to do things when there isn't when there's sort of an absence of halachic responsa on things. And I think that that's very helpful for me personally in counseling patients of my own, but also to continue the education of the community and especially Rebbeim, and who people will turn to, and they will turn to the medical professional as well. So this is very helpful, and it would be helpful to include the medical community in the outreach that everyone is doing.
Okay.
Wonderful. Thank you so much. I'm glad that we all learned from each other. And I hope that our viewers and listeners learned a lot too. Thank you.
Okay.